Well, hey everybody, this is Robert, and welcome to Outbreak News TV. Experts, right? There's experts saying a lot of different things, and there's still a lot of unknowns that go along with this pandemic. But I was really thrilled to see that earlier this week, or late last week, the group out of CIDRAP, the Center for Infectious Disease Research and Policy, up at the University of Minnesota, started producing called the CIDRAP Viewpoint concerning the COVID-19 pandemic. And they say that we appreciate that other expert groups have produced detailed plans for mitigating SARS coronavirus 2 transmission and for reopening the country after stay-at-home orders and other important mitigation steps are eased. Our intent with the viewpoint is to add key information and address issues that haven't garnered the attention they deserve and reflect a unique experience and expertise among the CIDRAP team and our expert consultants. And this team is pretty impressive. Of course, there's Dr. Christine Moore, Dr. Mark Lipsitch, John Barry, right, the author from The Great Influenza, excellent book on the 1918 pandemic. And of course, CIDRAP director Michael Osterholm. And then there's a whole group of other people working on this project. And this came through my email last week, and looks like they're going to be producing several sections to this viewpoint once or twice a week. So I'm very excited to see what they have to put out. It says, we will address timely issues with straight talk and clarity, which we definitely need. The steps we will recommend will be based on our current reality and best available data. Our goal is to help planners envision some of the situations that might present themselves later this year or next year, so that they can take key steps now while there's still time. And it says they're going to address topics like pandemic scenarios going forward, crisis communication, testing, contact tracing, and a number of other issues. So good stuff, interesting stuff. And if you're not familiar with the work at CIDRAP, I encourage you to check out their website at cidrap.edu. Well, let's go ahead and take a look at the first issue. And the CIDRAP Viewpoint, COVID-19. And on this one, they kind of focused it on the future of the COVID-19 pandemic, lessons from the pandemic influenza. Very, very interesting. So let's get right into it. It says, even though coronaviruses are very different from influenza viruses, the COVID-19 pandemic and pandemic influenza share several important similarities. First, SARS coronavirus 2 and a pandemic influenza virus are novel viral pathogens to which the global population has little or no pre-existing immunity, thereby resulting in worldwide susceptibility. So you have this very naive immune population. And we saw that really during a few years ago with Zika in South America and in North America. Very naive immunity population where it spread pretty quickly and caused some serious disease. Second, SARS coronavirus 2 and influenza viruses are predominantly spread via respiratory route by large droplets, but also with a significant component of transmission by smaller aerosols. Both have asymptomatic transmission, thereby contributing to the spread of each. Finally, both types are viruses capable of infecting millions of people and moving rapidly around the globe. But they also point out there are some differences. And I did talk about this with Dr. Amesh Adalja in a previous podcast a little over a month ago. And I'll put that above so you can take a look at that. First is the incubation period. The average incubation period for influenza is 2 days, whereas the average incubation period for COVID-19 is 5 days with a much wider range, as you can see. The longer incubation period for COVID-19 allows the virus to move silently in different populations before being detected. This contributed to an initial environment of complacency before national governments became aware of the severity. The second important factor is the asymptomatic fraction of the two infections. While COVID-19 is still pretty new and we're still learning a lot about it, public health officials have stated that 25% of all cases may be asymptomatic, in other words, no symptoms. And better serological studies may revise this percentage upward. A number of studies have explored the asymptomatic fraction for influenza, and one review found a pooled mean for the asymptomatic fraction of 16 with a range from 4 to 28. So while the viruses can lead to asymptomatic infections, it appears that the fraction is a little bit higher with COVID-19 than it is for influenza. Another consideration, they say, is the time frame of pre-symptomatic viral shedding. Very important stuff. And they had a recent study that showed that SARS coronavirus 2 viral load was highest at the time of symptom onset, suggesting that viral shedding may peak before symptoms occur. And that's a really, really important concerning the transmission of it. A point prevalence study of SARS coronavirus 2 in nursing home residents showed that for 27 residents who were asymptomatic at the time of testing, 24 developed symptoms a median of 4 days later, supporting the potential for several days of pre-symptomatic shedding. Now, with the H1N1 pandemic back in 2009-2010, one study showed that the viral shedding peaked the first 1 to 2 days after symptom onset, suggesting there may be less pre-symptomatic shedding for that virus compared to the virus we're dealing with now. And then there's transmissibility. And they say one way to quantify transmissibility is to determine the basic reproductive number, or the R0. The R0 is the average number of new infections that will result from a single infected person in a wholly susceptible population. And you could look at it with measles. If you have an R0 of, say, 18, which, measles is a highly, highly transmissible infectious disease, possibly the most of all of them. If a person with measles walks into a room of 10 people that are not vaccinated, never had measles before, 9 of them would come down with the disease. Now, the R0 can vary by factors that influence the contact rate between people, such as physical distancing strategies and lockdowns, aiming to drive the R0 below 1. An R0 below 1 indicates that the outbreak is shrinking rather than expanding, since each infected person is subsequently infecting less than one other person. While R0 is not influenced by herd immunity, either generated by natural infection or by vaccination, immunity in the population can influence the effective reproductive number, which is similar to the R0 but does not depend on having a fully susceptible population. Now, the R0 for SARS coronavirus 2 during the early course of the pandemic in China was estimated to be between 2 and 2.5. However, it's hard to accurately determine in various geographic regions because of the challenges in identifying and testing infected persons. One study suggested that the value may be quite a bit higher. So we really don't know about that. And then, of course, there's the issue of super spreaders, which we have seen with MERS coronavirus, say, in Korea. So that's always a factor that has to be taken in. Now, the R0 for pandemic influenza had varied by pandemic, but estimates have consistently been around below 2. So maybe the R0 for coronavirus 19 is slightly higher than we've seen with pandemic flus. Then they go over some other things, key lessons from past influenza pandemics. And they say of the 8 major pandemics that have occurred since the early 1700s, no clear seasonal pattern emerged for most. 2 started in the winter in the northern hemisphere, 3 in the spring, 1 in the summer, and 2 in the fall. The course of these pandemics was not substantially influenced by a vaccination campaign, except for the latest one, the H1N1, about a decade ago. But even then, the vaccine was initially available about 6 months after the onset. So still not quite clear how much that truly affected the pandemic. Key points from observing the epidemiology of past influenza pandemics that may provide insight into the COVID-19 pandemic include the following. First, the length of the pandemic will likely be 18 to 24 months as herd immunity gradually develops in the human population. This is going to take time, and serosurveillance data right now is very small. Given the transmissibility of SARS coronavirus 2, 60 to 70% of the population may need to be immune to reach a critical threshold of herd immunity. And it'll be very interesting to see how this works out in Sweden, where they've done things a little bit differently. And the top epidemiologist there thinks they will have herd immunity this month in May. So Outbreak News Today will be keeping a close eye on what's going on in Sweden. Then it says, second, there are several different scenarios for the future of a COVID pandemic. And some of these are consistent with what occurred in past influenza pandemics. And they summarize these three scenarios, and they're very interesting. They say scenario 1, the first wave of COVID-19 in spring 2020 is followed by a series of repetitive smaller waves that occurred through the summer and then consistently over a 1 to 2 year period, gradually diminishing in 2021. So we'll see. I don't think that's the likely one. Scenario 2, the first wave of COVID-19 in spring 2020 is followed by a larger wave in the fall or winter of 2020, and one or more smaller waves in 2021. This pattern will require the reinstitution of mitigation measures in the fall in an attempt to drive down spread of infection and prevent healthcare systems from being overwhelmed. This pattern is similar to what was seen in the 1918-19 pandemic, influenza pandemic. During that pandemic, a small wave began in March 1918, subsided during the summer months, and a much larger peak occurred in the fall of 1918. And there was later a third peak. And then finally in the summer of 1919, it pretty much ended. And then there's scenario 3. The first wave of COVID-19 in the spring of 2020 is followed by a slow burn of ongoing transmission and case occurrence, but without a clear wave pattern. Again, they say this pattern may vary somewhat. Geographically, it may be influenced by a degree of mitigation measures in place in various areas. While this third pattern was not seen with past influenza pandemics, it remains a possibility for COVID-19. So anyway, I just wanted to share this with you. CIDRAP will be sending these out once or twice a week, so keep your eye out for that. I'll go ahead and link to their website below so you can take a look at it and get on their email list for this and other valuable information they have. And good stuff, and we'll be keeping an eye on it, see what the experts have to say, and where this COVID-19 outbreak is going days from now, weeks from now, months from now. Anyway, again, thanks. Please go ahead and share this with your friends. Subscribe to the channel. Comment below. Let me know what you think, and I'll see you next time.